Thank you, and it is an honor to be speaking with you today. I have no disclosures that are relevant to the topic that I will be discussing. The primary driver of length of stay following traditional colorectal surgery, at least, is return of bowel function. And because of that, it's typically used by many, if not most surgeons, as a discharge criteria. And that's because ileus really was previously considered to be an unavoidable consequence of surgery. Return of bowel function can be measured in a myriad of ways. First described with the alvimipam trials in the early 2000s, GI-3 recovery is the triple crown achievement of passage of the first bowel movement, flatus, along with tolerating solid food without nausea. Whereas GI-2 recovery is the time in which the patient has had their first bowel movement and are tolerating solid food. This study, published in 2014, validated the GI Recovery 3 score. Using colorectal surgery patients that ingested a radioactive meal on postoperative day number 1 to assess gastric and subsequent colonic motility, the authors found that objective return of GI function using these radiographic objective criteria did correlate with return of bowel function for the passage of time to the first bowel movement and for toleration of solid food, but interestingly did not correlate with the time to passage of flatus. Now, despite the fact that GI-3 has been validated clinically, it does have limitations. The first being that the median time to first bowel movement varies based on the study characteristics as well as the patients that are included between 1 to 3 days postoperatively, and thus the patients will be reliably kept in the hospital for that duration of time. Additionally, GI-3 recovery does not adequately define ileus. There are various terms in the literature, and because of that, the incidence of ileus varies very widely throughout the literature, and that really has a significant impairment on research efforts. In truth, impairments of GI dysfunction occur along a spectrum of severity. Recognizing this limitation back in 2018, the American Society for Enhanced Recovery, along with the Perioperative Qualitative Initiative, brought a multidisciplinary group of international experts together and sought out to develop a score that really captured the various severity and signs of symptoms of ileus. And so the result was this IFEED score, which is based on the signs and symptoms that drive management decisions and correlate with worse outcomes. And although we thought it was a valid instrument at the time, it really needed to be validated in a clinical setting. And so I'll turn it over to Larry, who is going to discuss his research with the score. Thank you very much.
Hi. I'm Lawrence Lee. I'm one of the moderators of this session that unfortunately could not be here today, and I will be arguing that the IFEED score is the best metric for predicting outcomes following colorectal surgery. So the ideal metric would be objective, be able to track GI recovery, predict complications, as well as predict delayed GI recovery. It should also be simple and should also be validated. I will argue that the IFEED score, which is shown here consisting of 5 elements: intake, feeling nauseated, emesis, exam, and duration of symptoms, each of which you just scored on 3 levels and results in a score of 0 to 2, which would be counted as normal, 3 to 5, which would postoperative GI intolerance, and more than 6, which is postoperative GI dysfunction, is such a metric. This was first developed by the American Society of Enhanced Recovery as part of the Perioperative Quality Initiative, and has since been validated specifically within colorectal surgery. We have previously shown that the IFEED, when used to track GI symptoms after laparoscopic colectomy, follows 3 distinct trajectories, which you can be seen on this graph. Group 1, which is the solid bar, showing no GI symptoms throughout their postoperative stay, which is about 40% of the population. Group 2, which showed very early GI symptoms on post-op day 1, but with improvement over day 2 and day 3, which is about half of the patients, and group 3, which had early symptoms on day 1 and worsening over day 2 and day 3, which is about 11%. When you look at the patients within group 1, 2, and 3, the probability of uneventful recovery, which is defined as a maximum IFEAT category as normal, which is basically no symptoms, length of stay less than 3 days, and no 30-day complications, ED visits, or readmissions, was highest in group 1, which is not unsurprising at about 74%, to 0 in group 3. The IFEAT score also predicts outcomes. We have shown, as part of this same study, that the IFEAT score of less or equal than 1 on postoperative day 1 had a high probability of predicting patients who had an uneventful recovery, with very good diagnostic characteristics, as you can see at the bottom of the graph. Finally, we've also been able to show that outcomes can be predicted as early as postoperative day 0. In one study, we showed that about 70% of patients tolerated clear liquids right after laparoscopic colectomy, and these patients were highly likely to have an IFEAT of less than or equal to 1 on postoperative day 1, as well as had an overall better trajectory of the IFEAT scored over the first 3 postoperative days. So in summary, the IFEAT score is a very easy to use metric that is validated and predicts postoperative outcomes and GI recovery after laparoscopic colectomy.